Hello and welcome everyone to a new episode of the Menopause Symposium, where we bring you new and exciting updates from the world of menopause. My name is Bassel Wattar. I'm an associate professor of reproductive medicine and menopause specialist from South London. And I'm joined by my friend and colleague, Dr. Vikram Talaulikar, who is a menopause specialist from University College London. Vikram, how are you today?
I'm good, Bassel,
Yeah.
and looking forward to another exciting discussion. Thank you.
Indeed, and we're recording this in the shadow of the Euros games, and we're very excited to see how the English team will do. So sticking away from sports, today, and in the spirit of athleticism, we're bringing a very interesting article about the effect of Ozempic treatment on weight loss in the menopause. And I'm sure, like many, Vikram, as a gynecologist and a clinician, you've been hearing a lot about the impact of Ozempic. What has been your clinical experience using it in the context of menopause?
Not a lot of experience, I must confess, specifically in relation to menopause, because mostly rapid weight loss with any injections or oral medications like the GLP agonist. It's more sort of in fertility context, younger women trying to lose weight quicker because they've exhausted all other options and they may be running out of time for fertility. That's really where I have sort of come across use of semaglutide or liraglutide. But it is interesting because weight gain is a prominent feature during midlife, during menopause transition. We know insulin resistance goes up as estrogen declines. So in a way, it's good that we are discussing this paper. It's a good selection by you because we will hear more about this, the role of these GLP agonists, besides lifestyle in managing weight gain and achieving weight loss during menopause transition. So experience-wise, very little so far, but interesting where future takes us as these agents get more and more used more frequently.
Indeed, I completely agree with you, and I've been predominantly using it for my PCOS and fertility patients. However, to emphasize, these are it's not recommended to get pregnant while you are on semaglutide. So we need to use a reliable contraception and allow a wash-up period before trying for pregnancy. So this article by Hurtado et al. Coming from the USA is basically giving us a little bit of an early insight into what is the sort of predicted or like a perceived improvement in weight loss for women who are using semaglutide in the menopause with or without HRT. And before we start, I mean, from your perspective, does HRT help with weight loss, or what would be your sort of clinical take on it?
So I wouldn't classify HRT as weight loss medication. And that's what I say, because often the hope is that once I start HRT, any weight gain that has happened in midlife with the menopause transition will go away. That's often the picture in the mind. That is not true. You see so many women who continue to gain weight despite using good doses of HRT or testosterone. But you also have women who, after starting HRT and testosterone, do report weight loss. And what is the common observation is it's not the direct impact of sort of metabolic pathways that the estrogen causes, but often they're sleeping better, their quality of life is better, they exercise more, the joint pains are gone, you're more motivated, less fatigued. And that brings in a sort of boost to weight loss activities that that individual may undertake. That's how in some group of women, it looks like HRT does benefit indirectly because it is going to make them more proactive and more functional.
100%, I completely agree. So this study is a retrospective observational exercise where they basically use the database of the Mayo Clinic health system in the USA. And obviously, Mayo Clinic is not just one clinic, it's a conglomerate of several clinics. So we're not very clear how many centers were contributing to this data set. And they basically collected the data between 2021 and 2023, and they looked into all women who are in the menopause and they had a BMI above 27 and they have used semaglutide for more than 3 months. And that was the main sort of hypothesis of this exercise is, does the use of semaglutide in these overweight or obese women with the use of HRT or not, you know, change how the weight loss transpire. So the inclusion criteria, as we discussed, is that these women need to be in the menopause, defined as over 40 with 12 months of amenorrhea as a clinical diagnosis, or those with a hysterectomy, they need to have an FSH greater than 50 to be included in this study. Women in the no HRT group or those who allocated to the no HRT group needed to never have received HRT. And those included in the HRT group only were if the HRT was started prior to semaglutide initiation. And obviously, in terms of the inclusion criteria, as we discussed, they needed to have used semaglutide for 3 months or more, and they needed to never have received bariatric surgery or active cancer, and it didn't matter what sort of HRT they use, whether it's transdermal or oral or any other format. The data, obviously, they harvested the data electronically and they segmented it into depending on the duration of using semaglutide for 3, 6, 9, and 12 months. They allowed the 30 days sort of range for each time point. And they also collected important demographics and sort of baseline characteristics on the age, race, ethnicity, marital status, level of education, and financial situation function. Which are routinely collected data in the USA because of the insurance system. Additional data, they were collected on the anthropometric outcomes, weight, height, BMI, blood pressure, and as well as cardiovascular risks or disorders, dyslipidemia, hypertension, type 2 diabetes, gastroesophageal reflux, liver disease, sleep apnea, and then their metabolic sort of surrogate markers like HbA1c and lipid profile. They also captured what sort of medication they have been using, and they split the data depending on the dose of the semaglutide to low and high. Now, interestingly, they used 0.25 to 1 as low and a high dose as 1.7 to 2.4. So I'm not sure if someone was between the 1 and 1.7. Where did they put them? It's not very clear in the data set. I mean, clinically, what sort of doses have you come across? I've seen so many different protocols for use in clinical practice so far. And what would you reflect with our audience?
I think most patients who have usually received this treatment through, say, endocrinologist or other physicians have often been on the 1 milligram dose.
Yeah.
And I think, Bassel, you mentioned that's probably the dose that most patients you see as well will be
Indeed.
on.
Indeed. I wouldn't recommend to going to a very high dose because that's often where you see the side effects. And I think also a tapering sort of build up to the 1 milligram is sometimes recommended so that it allows more sort of adjustment for the medication and not seeing the common side effects like headaches or nausea and vomiting and so on. So let's dive into before we carry on. So the outcome obviously was the total body weight loss percent at 12 months, and they looked into it in every sort of 3 months iterations. And the way they calculated the total body weight loss percent is using this formula. So 100 multiplied by weight at baseline visits minus the weight at follow-up visit divided on the weight at baseline visit. And then, as I mentioned, they looked into the total body loss percent at 3, 6, and 9 months. And they also looked into the proportions of those achieving 5, 10, 15, and 20%. I mean, 20% total body weight loss is a bit excessive. I think clinically, if you agree, a 5 to 10% is usually sufficient to see a significant improvement in cardiometabolic profile, isn't it?
That's right. That's right.
And they also captured all these other sort of surrogate markers that we discussed in terms of blood pressure as well as blood markers. And they did a subgroup analysis per category of semaglutide use, high and low. Statistical analysis, they applied somewhat sort of traditional approach where they used a multiple regression analyses, and they adjusted for key variables at baseline like age and type 2 diabetes and nutritional behavior support. Now, it seems like in this particular clinic, they offer nutritional behavior support as sort of um, routine practice, but there was not much description in the article about what nature of this nutritional behavior support, or whether it actually varied from one person to the other, or if there was a standardized protocol. So that's potentially an interesting point of performance bias in this article to bear in mind. Now, looking into the data, where they started in 1,023 person or participant who had semaglutide. Some of them were men and they were excluded. And they went all the way and they identified 150 women above the age of 49. They excluded a further 53 of them. Some of them were premenopausal and so on. Eventually, 106 were included in this study. So it's quite an interesting attrition. The interesting finding is that only 16 were actually on HRT and 90 were not on HRT. So that slightly, I would say it's a small sample size, and it might limit the generalizability of this exercise, but still very interesting data and rather early data to see. In terms of the baseline sort of characteristics, majority were white, married, college-educated women in their late 50s, with a BMI obesity category of 2, which is expected. Most were not on HRT, as we discussed, and 50% used transdermal estradiol at variable doses, which is, again, I think, consistent with current modern practice, and about 38% were on oral progesterone.
Bassel, if I interrupt you there,
Please.
Interesting thing in the table is those adiposity-related diseases, and the one which is the dyslipidemia and the depression, where there seems to be some sort of baseline statistical difference. One wonders whether it's the HRT giving the favorable result in the HRT group of already maintaining good lipids and perhaps also having some impact on the mood. So you see overall less of these problems in the HRT group. But again, it's 16. So really, you can't say anything with 16 people. But just to note that at baseline, it seemed that people on HRT seem to have already less problems with lipidemia and the mood issues on HRT.
Yeah. Which is consistent with the literature, isn't it? And what you would see. So it's a very, well-spotted observation. Thank you, Vikram. So let's move into the actual results, and in terms of how many of them, what sort of weight loss was achieved. So in the women using the HRT, the most common adiposity-related diseases were hypertension and gastroesophageal reflux and dyslipidemia, but this was also similar in the non-HRT groups. And then there were no statistically significant difference except for dyslipidemia and depression, which again you've alluded to already, Vikram, in the previous table. And pretty much everyone who was going on semaglutide, they were improving sort of their cardiometabolic outcome and risk, which what you would expect while going on semaglutide. They mentioned that there is no difference in nutritional behavior support, which I've alluded to already. Again, this is a bit vague in the article, and we're not sure what does that entail, or what's the nature of the support, or whether there are any variations between the participants, or there any standardized protocols for it. Now, the interesting element is that those who are not on HRT, so those who are on HRT compared to non-HRT use, achieved higher weight. So there were higher weight loss with HRT at 3, 6, 9, and 12 months. So that is ranging from 7 months at 3 months, 7% weight loss at 3 months, all the way to 16% weight loss at 12 months, which is really, really significant and great. And I think the difference between both groups is sort of consistent. So there is always about 2 to 3% difference at each time point. And similarly, compared to no HRT users, there were higher proportion of women using HRT achieving 5 and 10% body weight at 12 months, but this was not translated to a statistically significant difference for 15 and 20% total body weight loss. I mean, again, clinically, it's rare to see 15 and 20% total body weight loss in that short period of time, isn't it? So you wouldn't expect to see it in this study. And even when they adjusted for the semaglutide dose, there were the differences persisted. And when they did the subgroup analysis for the high dose, the difference among the two groups in total body weight loss at all points, to all time points and proportions also persisted. So that's reassuring in that irrespective of the dose of semaglutide, there was this sort of pronounced and sustainable weight loss with HRT. Moving to the next slide, I think that's sort of a table summarizing these time points that we discussed, and they sort of allude to here in the second one about whether they had the psychology visit or dietitian visit, and they had diabetes or not. And I think these factors that they adjusted for, but again, I think in the methods section they did not really explain what happened in these psychology supports and what happened in the dietitian visit. That's the important points to highlight. Now, looking into the cardiometabolic risk markers, and it's a little bit busy slides, but basically we're seeing fasting glucose, blood pressure changes, LDL, HDL, or all the lipids, as well as HbA1c. And all across the plot, basically we're seeing that there were improvements with all these variables with the use of semaglutide, irrespective of HRT. So with or without HRT, both groups were having improvement from baselines, and HRT did not yield significant difference. But again, we're dealing with a 16 women cohort, which is a little bit small. And that was also irrespective of the high dose. Oops. So what do you think of findings, Vikram, and what are your thoughts about the limitations of this study?
So findings are as expected, if you agree, Bassel. So one would expect both the weight to go down with semaglutide. All the cardiometabolic profiles improve with semaglutide. We know that's the action. In terms of how much influence HRT had together with semaglutide, the numbers are really too small. This could just be really still chance event that you saw that the reductions were higher in the HRT group. But there are many other things that could explain. For example, HRT improves somebody's energy levels, takes away the fatigue. So that group of women may be exercising more. They may be putting in, they may be sleeping better. Sleep has an effect on weight gain. So better sleep might have contributed to it. Similarly, again, exercise-wise, they would be probably more health conscious if they are on HRT. Often the problem that happens with HRT group in trials is if you're already starting with a group who is using HRT, they tend to be maybe a little bit more health conscious. They have a better diet. They are following more of healthy lifestyle options, and you necessarily don't account for all of them. And that means that you're always likely to get better results in the HRT group. So all that could have had a bearing on the results. But certainly it looks from the study head to head, there was some synergistic help from the HRT use and the variables that go with it, and the semaglutide in addition.
Yeah, I think it's interesting from a mechanistic perspective to see this synergy between the HRT and the semaglutide, and how the weight gain is probably a bit more pronounced and a bit more achievable. I've been, since reading this article, and I think this is more a sort of a hypothesis sort of testing article. or like I've been debating what sort of RCT we would need to do to sort of standardize the use of semaglutide in menopause. And I'm struggling to come up with a great idea, because I think if we are asking the question, does semaglutide reduce weight? We know by now that it reduces weight significantly. I think the more interesting outcome would be, does the use of semaglutide and HRT together versus no HRT optimize menopausal symptoms? And that's, I think, what we're not very sure about. Um, um, and again, use of HRT in itself is a covariate, so it's going to be interesting to see how the evidence materialize in this space, isn't it?
Yes, absolutely. We need to learn a lot more about how which sort of subgroup of women the semaglutide will make the biggest difference, and the benefits we'll get will outweigh any side effect or risk.
Mhm.
We know generally, we know, for example, women with BMI about 35, those above 40, comorbidities, diabetes, already problems with high BMI. We certainly know those are the groups right now, irrespective of age, where these medications are primarily recommended or used. Now, in menopause, do the same criteria apply, or is that another subgroup where you might find that using it besides interventions such as lifestyle HRT may cause quicker weight loss and improvement in cardiometabolic profile? That means that individual has a better long-term health. We're not there yet. I guess that needs to be determined first before we recommend it to a particular group in this age
Yeah.
group.
Yeah, 100%. And I think also is the timing of when to give the semaglutide, because you'd argue there is a sort of a golden, similar to HRT, there's a golden window of opportunity where you're in the early 50s, like this 51, 52, where women traditionally would start seeing more of central obesity as they edge into the menopause. So you'd argue that doing this intensive intervention of semaglutide for like 3 or 6 months and shift off 10% of body weight, that can help significantly to ease someone into the menopause transition without seeing any major sort of adverse outcome in their cardiovascular health, isn't it? Rather than waiting for 10 years down the
Yes,
line and then see how
yes,
things will materialize.
true, very true.
Well, all these are hypotheses that I think will wait for more evidence to materialize. So, what would you say is the take-home message for our viewers today, Vikram, from this article?
So I think the message here is, um, it's not a magic potion, semaglutide or liraglutide or the GLP. They're here to stay, but they're not a magic potion. They have their own unique benefits, side effects, and risk. If you have to lose weight, then almost all of us, Bassel, me, you, and any, I think, physician will always recommend lifestyle factors as the best way to do it. Because
Yeah,
remember that although the GLP might drop your weight in the short term, studies do show that after 2 years, you tend to gain your weight back unless you've really corrected the lifestyle in a massive change. You might come back to your original weight in the next few months or years once you've stopped having the semaglutide. So it's not a permanent change. And so it's really important to focus on lifestyle first. If that solves the problem with weight gain, nothing better. Semaglutide should be reserved as a next strategy. But
yes.
for those women, as we said, subgroup of women where lifestyle factors have been exhausted, they're not working, or they may be in a unique situation where a rapid weight loss may benefit them before any cardiometabolic damage is done. And as I said before, we're not clear entirely which this group of women is, but there might be evidence as it emerges that as women then go through these menopausal transition, and if they're really having a major knock-on their cardiometabolic profile, they could then consider hormone replacement, lifestyle, diet, exercise, cognitive behavioral therapy, and the GLP as one
Yeah.
of the option alongside. And that might be the multifactorial approach to treating obesity, mainly primarily, or very significant weight gain in that particular cohort of women. That would be my message right now until we see more used GLP in future.
I completely agree. I think both of us in our clinical practice, we always hone on the importance of holistic approach to menopause management. It's not just the semaglutide that is going to resolve the situation. So it needs to be sort of all multidisciplinary and really tailored to the individual need of every patient. Fully agree. And I think particularly it's probably semaglutide is to be prioritized in these subgroups who are, for example, pre-diabetic, or they have morbid obesity and they want to have limited mobility and they want to shift that, avoid bariatric surgery, for example. I think these are successful users of semaglutide. But like you said, I don't think it's fit for the whole menopause population. It should
Yes,
not be,
yes,
used and described as tic tacs, like I think what's happening in some countries and some particular settings. I think grounding the use in evidence is always key. Fantastic. I think this has been a quite a thrilling discussion and always exciting to be discussing these new emerging treatments and offering new updates to our audience. So thank you very much, Vikram, for joining today, and thank
thank
you
you,
all
Bassel.
for watching us. And as always, please do support us by liking the content and the channel, subscribing, and send us your comments, whether on YouTube or whether on LinkedIn. We're very keen to stay in touch and see you in the next episode. Thank you, Vikram.
Thank you very much.